everybody. Welcome to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm Kiley Como. I'm a nurse with Shane Smith Law, and we're back again today talking with our friend, Dr. Mbeo. Dr. Mbeo, it is always good to see you. Can you expand on any other, talking about emerging treatments and technologies, what else have you run across and you're seeing yourself deploy there in your practice?
So interesting. So again, emerging therapies in the setting of traumatic brain injury. So many of these are directed at these persistent symptoms. Persistent symptoms that are so difficult to control. And I'll talk about headache as an example. So really common as a consequence of a traumatic brain injury is new onset of headaches or a transformation in the quality of pre-existing headaches. What do I mean? Some patients who already had migraine headaches and then perhaps suffered a migraine headache maybe once or twice a month or maybe every few months now find themselves in a place where their migraines transform in frequency and intensity. So they are a lot more intense, a lot more frequent. They go from a few times a month or maybe a few times a year to almost daily migraine-like headaches or even changes in how their headaches behave. So these refractory headaches. And then not only those types of headaches, there's also what we call cranial neuralgia. So nerves that just become sensitive after this concussion, head and neck nerves. So we call those cranial neuralgias. And some of the common ones that patients that have had a traumatic brain injury unfortunately end up suffering from become supratrochlear and supraorbital, so above the eye. And so not unusual for patients to tell me, Dr. Mbeo, it feels like an ice pick in my eye, or it feels like something sharp being jabbed around my eye, or what we call auriculotemporal neuralgia. So on the temporal aspect of the head, again, just really sensitive branches of the head and neck nerve, the trigeminal nerve, really sensitive, auriculotemporal. And so that, my head right about here is where the pain is. Occipital neuralgia, so the back of the head. And as we take that headache history, I usually try to understand, where do you notice the pain? Is it on the back? Is it on the side? Is it on the front? Is it all over? Occipital neuralgia, quite common as one of those refractory cranial neuralgias. So the back of the head nerve becomes really sensitive, and it could be one side, could be both sides, and it could happen alongside all these other neuralgias we're talking about. So these really difficult to control headache syndromes. Now, as we look through how do we help with these, what's old and what's new. So what's old and been tried and what's new and emerging as a therapy. So old and been tried is typically we will go through the traditional classes of medicines we would use in these headache syndromes. We'll talk about the antidepressant class of medicines, tricyclic antidepressants. Nortriptyline is an example. So it's an antidepressant medicine that does give benefit in headaches. We talk about the nerve stabilizing medicines, things that gabapentin becomes one that comes to mind. We think about anti-seizure medicines that have a role in helping these headaches. So think like topiramate or Topamax. The challenge with a lot of the old and tried medications is fine. They have a history behind them. A lot of these patients are already dealing with cognitive consequences of a brain injury. And then a lot of these medicines also have cognitive side effects. So it becomes challenging adding on a cognitive altering medicine to somebody who already has cognitive symptoms from their traumatic brain injury. So looking at newer medications or newer strategies is key in patients with these headaches. Newer interventions, medication sparing interventions, Botox. And many times when I talk to my patients about it, we have a chuckle, we share a laugh, and we say, well, hey, it's not cosmetic Botox, but hey, once we're done putting Botox into those sensitive areas, perhaps we'll use some here and here and maybe on a crow's foot here and here and things like that. And so we share a chuckle, but Botox, and Botox has an interesting mechanism of action. So it's an intervention, it's a series of injections that we provide every 3 months. It can be anywhere from 2 cycles of Botox to might end up being a little longer as far as cycles of Botox every 3 months. And what we're doing is we're targeting those areas that become really sensitive. So we're talking frontal, we're talking temporal, we're talking back of the head, the occipital, we're talking in the cervical, the neck muscles, and the trapezius muscles. So those are well-studied protocols that we're using to try and help calm down overly sensitive nerves relax muscles. And interesting, so we thought it just used to be a muscle relaxing effect that Botox gives, but no, it actually has a pain blocking effect on pain pathways that have been sensitized. So Botox becomes a way that keeps us from having to add on medicines or use medicines that might have other side effects. So that's one of the emerging therapies for patients with these cranial neuralgias. Now, another emerging and medication sparing strategy is starting off with what are called nerve blocks. So we've used nerve blocks for many years. So nerve blocks, so if we're able to identify those sensitive nerves, so talk about supratrochlear or supraorbital or even occipital nerves. So if we're able to identify them based on the patient's history and then a careful exam by a neurologist, if we can identify those nerves, then what we're able to do is use medications, many times local anesthetic medications, to block the nerve, put the nerve to sleep. And it acts in effect like hitting the reset button. Computers malfunctioning, hit the reset button or power it down and then let it wake back up. Works in a similar way. Now, an interesting extension to that, to make it last even longer, is what we call ablation. So ablative therapy. So it's a way that we're able to put that nerve to sleep for longer than a few hours. In fact, could last months. Up to a year is the best that we've seen with ablation therapy. So ablation therapy. And there's various types of ablations. There's ways we can use heat-directed ablation. And then what's really interesting is what's called cryoablation, so cooling ablation, where we pass cooling energy to the nerve, and when we're really cooling it to a degree where it allows that energy to inactivate the nerve for a long amount of time. So cryotherapy or cryoablation. And there's different devices. There's interesting devices that we can use. And again, helps us hit that reset button and then keep it in that hibernate mode for the amount of time it takes for the nerve to regenerate, wake back up, without that abnormal pain signal it was sending. So emerging therapy that allows us not to need too many medicines. Other emerging therapies that we can use that again will be medication sparing and saves us from having to add on medication on top of medication to a patient who already has a host of medicines in traumatic brain injury headaches, is what is called the Sphenocath, and that's quite exciting. Sphenocath, or the sphenopalatine ganglion block. So the Sphenocath is what it's called in short. Now, Sphenocath is a device that allows us to deliver carefully dosed amounts of medications. Usually it's going to be a local anesthetic to a part in the central nervous system that we access through the nostril. So it's again a clinic done procedure. It's done at the bedside, takes a few minutes, and we're able to deliver very carefully using that Sphenocath, a specially designed catheter, doses of local anesthetic. Now, the reason we're targeting the sphenopalatine ganglion is because in a lot of these patients that have refractory headaches and post-traumatic headaches, that particular collection of nerves, so a ganglion is a collection of nerves, that particular collection of nerves is in overdrive. It's just firing off pain signals. It's been angered, and you can imagine it as just pulsating and giving pain signals that go to the head and cause these bad headaches. Using a Sphenocath, we're able to gently and carefully direct our attention to that ganglion in the nose. It sits right, we can access it right next to the nose. And then as we get to the ganglion, deliver that local anesthetic medicine. And then what that does, that same thing, it allows us to hit the reset button on this collection of nerves that's just causing refractory pain. So again, we've talked about some, there's many others, but then some of these emerging treatments that allow us to use less medicine and then take away this really difficult to control headache syndrome that happens in traumatic brain injury.
That is fantastic. It's funny you mentioned the sphenoganglion block. I actually was doing a little bit of digging several weeks ago. Wasn't familiar with that procedure, so I dug in and actually have a little poster of it in my office now because it's just such a fascinating procedure done right there at the bedside. Like I said, so all of these processes, the transcranial magnetic stimulation you talked about, the nerve block, the ablation, the sphenogang block, those are all done there in your office?
Absolutely, all done in the office. Some needing, maybe a little bit of local anesthetic to make it tolerable. Some, in fact, most tolerable without the need for local anesthetic and things like that. So done in the office, done at the bedside, tolerated by vast majority. Most people will tolerate it. Minimal side effects, minimal discomfort, and usually, as I talk to my patients about it, it's few moments of discomfort to allow for sustained relief of this, these things that have been been aggravating. So it becomes the nerve blocks. Just a few moments of discomfort, hopefully, is going to lead to months of alleviation of these headaches.
That's great. Again, I think that's just such an encouragement to many people out there to know that, hesitate to reduce it to a one-stop shop, where you can go and basically have all these treatments right there at your fingertips without having to travel here, there, and everywhere. We've had clients that have had to travel, across state lines for certain treatments. And so, again, very, very exciting to know that, you are championing kind of that all-inclusive approach in your offices. So I did want to ask, we do have several clients that come to us kind of later in the process. They've been dealing with things for quite some time, and many of them are despondent and don't think that, because they've been dealing with so long, maybe they can't get better. Is this something, are these treatments something, or concussions in general? You hear early treatment is best, but say you're a year, maybe 2 years into this, is there hope using these kinds of procedures for people like that?
That's a great question. Earlier treatment, we advocate for earlier treatment. So earlier diagnosis and earlier treatments, earlier interventions. And in the clinical studies looking at concussion, patients that did have an opportunity for an earlier diagnosis and earlier initiation of therapies, they tended to do better. And then, unfortunately, whenever the symptoms last longer, it becomes a little more challenging because many of these challenges or these deficits become harder wired into the brain circuitry. That being said, we used to think about it as hard and fast, that once we hit the 12-month mark, there's little to no chance of meaningful benefit. But no, we're learning that targeted benefits, and that's what I talk to my patients about. I say, well, hey, we might be 2 years out or 3 years out. That doesn't mean that we cannot help at all. It's not likely that we will get back to that pre-concussion baseline, perhaps not, but hey, if we're able to take away some of what's aggravating, so let's take away the headache that might give a 30% benefit, let's say, and even that is that's something in somebody who's dealing with headache and the depression and the PTSD and the heightened anxiety and the cognitive fatigue and the sleep deprivation and things like that. So even taking away 1, 2, 3 of those things that afflict them, it could even be years down the line. Even helping with that makes quite an impact in many of these individuals. So hope is not lost. So along the spectrum, earlier is better as far as diagnosing and initiating therapies. But even when we catch symptoms further down the line, targeted therapies, if it's a headache, so really trying to identify novel ways to help with that headache can help. If it's going to be the dizziness that just has afflicted them for the last year, 2 years since the concussion occurred, targeted therapies to try and help with the dizziness and balance dysfunction, be it PTSD and heightened anxiety, targeted therapies for that. And so, like we said, we may not be able to get them back to that baseline that they were pre-concussion, but even just taking away some of what afflicts them, low-hanging fruit after low-hanging fruit, does make a difference. So I tell my patients, at whatever stage, let's have a sit down, let's talk through symptoms, let's see what we're able to identify, and then treat one low-hanging fruit at a time. And that, even just that, the fact that there's hope that there are some things that can be tried and targeted, they appreciate that.
Yeah, I think that's one of the things I admire about your approach to practice, neurology and how you treat concussions. It's just the comprehensive assessment. You mentioned it earlier, right? Again, not saying anything about any other neurologists or concussion practices, but really digging in and digging into that individual's case. You ran off a litany of questions and tests that you go through to just get at the baseline of where a patient or a client might be. And so I think it's just a matter of finding, the right kind of provider such as yourself to get in to maybe have that bit of hope that they thought was lost. So again, very encouraging.
Thank you, and I believe it's a matter of disseminating this to the general public and to other practitioners, just helping all of us stay up to date about what's new and what's available as far as our treatments. For a long time we've lived a life where all we could do, especially as neurologists, was diagnose, and that was about it. In fact, the term was diagnose and adios is what neurology used to be seen as. Really sophisticated at making complex diagnoses, but perhaps neurologists not as equipped to offer therapies. But that's changed, and it's changed quite a bit. And so disseminating that to the public and to other healthcare practitioners, it helps everyone understand that there are options across the spectrum. Early on, there are options, and then further down the line, there are options. And as we all start to understand that there are options, then I think it allows us, allows everyone to benefit from, these many options that exist in helping with TBI and the TBI consequences.
Okay, everyone, that's going to do it for another exciting episode of Mind Matters, Navigating Head Injuries and Concussions. Thank you, Dr. Mbeo, once again for coming along and sharing your expertise and your passion with us today. Everybody, please don't forget to come back next time where we're going to be continuing our chat with Dr. Mbeo about emerging treatments and technologies to treat brain injury. So again, to you in the audience, please remember to hit that like and subscribe button and stay up to date on all of our latest and greatest content. Hit that bell for notifications. And remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.